Yeah.
Can we start the live stream, please? Thank you. Right, I make it 2:00, everyone. If we can start. Good afternoon, everyone. My name is Councillor Bethan Eddy, and I'd like to welcome you to the July Health and Wellbeing. I'll do a quick thank you to Councillor Dr. Doddy for all the work that he's done on the Health and Wellbeing Board and for health and wellbeing in Nottinghamshire as a whole. I'd like to thank him for the championing of the water fluoridation and also for the sustainable food motion that he did. And I'd like to thank him for all the time and commitment that he has taken on this committee. So, and then let us begin. So, the first thing we've got to do is the membership of the Health and Wellbeing Board for the 24-25 year as listed in item 1 on the agenda pack. I don't think Natalie's here, but it would have been her first meeting. So please can I take that as everyone is happy with the membership, and show of hands, please. Item 2 on the agenda are the minutes of the last meeting. Now, I wasn't here at the last meeting, so if there's any issues. So can the board agree the minutes are an accurate record of the last meeting held on Wednesday the 22nd? I'll go through the minutes per page if there's any issues. So page 1, page 2, page 3, page 4, 5, 6, 7, 8. No? Does everyone have to take them as an accurate record? Can we have a show of hands, please? Thank you very much. So agenda item 3 are apologies for absence, and I'll pass over to James Lavender from Democratic Services, who will tell us.
Thank you, Chair. So we have received apologies from David Briggs, Fiona Callaghan, Sarah Collis, Colin Pettigrew, Melanie Williams, and Councillor Lynn Schuller. Thank you, Chair.
Thank you. So, item 4, declarations of interest. Does any councillor or officer have any interest in the matter on the agenda that they would like to disclose? Councillor Wheeler.
Yeah, thank you, Chairman. Just for transparency, I'm obviously here my hat on as Russia Borough Councillor, but I do obviously have a role as the Cabinet Fellow at Social Care at the County, and a couple of the items have been brought to my attention before the meeting, but I've not taken a formal decision on them. So, obviously, I'm fine to be here and vote on it, but I just wanted to raise that for transparency.
Brilliant. Thank you very much. Is there anybody else? No? Fabulous. Let's move on then to the first proper item on the agenda. Item 5. So, first on the agenda, we have the Health Protection Report. This is intended to be an update on behalf of Nottingham and Nottinghamshire Health and Protection Wellbeing Board, and to give assurance to the Health and Wellbeing Board that outcomes and arrangements for health protection in the county are satisfactory. Before I hand over to Lucy Rutter, can I have a seconder, please, to formally move recommendations? Thank you. So, over to you, Lucy, and then I think we're going to hand over to Sarah Mayfield, who will do a presentation on vaccination rates. Thank you.
Hi there, colleagues. My name is Lucy Rutter. I'm a consultant in public health, and I'm the consultant lead for health protection here at Notts County Council. But here today representing the Nottingham and Nottinghamshire Health Protection Board, which feeds into the Health and Wellbeing Board, and presenting to you our annual report, which is designed to give you that assurance that we've got arrangements in place for health protection within the county, and the outcomes from a health protection perspective are satisfactory. So as a quick précis, health protection is concerned with preventing or reducing harm caused by infectious diseases, but also minimising the health impacts of environmental hazards such as extreme weather and flooding, but also covers things such as air quality and community infection control. So quite a broad ranging remit there. The report itself, I'm not planning to go through in detail. We want to allow time for questions and discussion, but covers our performance and actions around the national programmes for routine childhood and adult vaccination, national screening programmes, our local management of environmental hazards, our health emergency preparedness and response, and our community infection control arrangements for health and care settings. And just want to emphasise that health protection really is a whole system collaborative approach. So the Health Protection Board is a multi-agency board comprising the UK Health Security Agency, formerly Public Health England, the Nottingham and Nottinghamshire Integrated Care Board, so representing the NHS England, and then city and county public health teams. If colleagues had a chance to read through the report, you'll see that on the vast majority of outcomes and indicators, Nottinghamshire is performing at or above national and regional levels, so performance is good in most areas. But one area where we are seeing perhaps some cause for concern is around immunisation coverage, particularly in childhood vaccination programmes. Just want to emphasise that's not unique to Nottinghamshire. We're not an outlier in that respect. That really mirrors a national trend we've been seeing over several years, particularly post-COVID, of childhood immunisation rates declining. So with that in mind, we thought it would be helpful to invite a colleague. This is Sarah Mayfield. She's the Senior Screening and Immunisation Manager with NHS England, who commission childhood immunisation programmes, and she's going to present some additional information around vaccination rates in Nottinghamshire. And Lizzie, I don't know if you've got the slides to pop up there. Yeah, just press that.
Hi everyone, thanks for having me today. As Lucy said, I work for NHS England, who are the lead commissioner for vaccination programmes nationally that are then implemented locally with the support of ICB and local authority colleagues. Next slide, please. So we thought it would be helpful to bring today some of the key vaccination programme data slides. So this first slide here is what we called cover data, and cover data is extracted from GP systems nationally by UK HSA. We receive this data quarterly, and it helps us to see the trends in vaccination uptake. This data, we can see at local authority level data, but we can break it down to PCN and practice level data. For a lot of programmes, Nottinghamshire either performs better than the England average or in line with. So the first two top tables are, so the first table is the primary vaccination course that a baby requires by the age of 1, and they're normally given at 2, 3 and 4 months. And that's also the case for MMR1, which needs to be given by 2 years of age. The two bottom tables are the areas where we are trying to do more work at the moment, and that is the preschool booster, which is a pertussis-containing vaccine, which you will have heard that we've had cases of whooping cough in the area, and so it's really important that we try and increase uptake for that vaccine. And also MMR at 5 years of age. Again, we can see the trend is that although we're slightly above the national average, we're not at that 95%, which the World Health Organization asks us to try and ensure that vaccinations are at 95%, so that we create herd immunity, which means that anyone that's not vaccinated will get that wider protection from more people being vaccinated. So there are lots of initiatives taking place to try and increase uptake in these areas. We've just implemented a missing immunisation list that's going to GP practices, to every GP practice in Nottingham and Nottinghamshire, so they can see all the children that aren't up to date with their vaccinations and invite them in. So that's a phase of doing it for the under 5s, and then we'll do it for the over 5s as well. So that will be a monthly refresh. So we're hoping that will ensure that everybody that's eligible is invited. There's lots of community engagement work going on. We have set up a specific pertussis whooping cough working group and a measles working group as well, so we can engage our health visitor partners, our school nurses and the wider system to try and increase uptake within the area. Next slide, please. So this just shows you the trend, and again, as Lucy said, we've seen a 10-year decline in vaccination uptake nationally and locally. So the dotted line is the England uptake, and you can see the Nottinghamshire blue line is above, but still kind of following that trend. And the other slide is you're the blue line, and that's just compared to similar local authorities. So you kind of slap bang in the middle there. Next slide, please. So as we've been seeing cases of measles, this was a piece of work that we did collaboratively with the public health team here within Nottinghamshire County Council, just to see where those areas of more susceptibility for measles cases would be, so that we can target that work. So this is just an example of how we can drill down into the data and then focus the work where it's particularly needed. Next slide, please. So this is data on the children's flu programme for 2 and 3 year olds, which is delivered by GPs. Again, so with this programme, we don't need to be at 95%. It's a much lower rate. Ideally, between 40 and 60%, we need to stop that circulation of flu in the wider population. So just above that for Nottinghamshire, ideally, we would like to do more work on this. And we're hoping that this year, because GPs are going to dedicate September for children and pregnant women for flu, and then do adults separately, we're hoping that we might be able to increase that uptake. Next slide, please. This is a slide just showing you the school-aged immunisation programme data. So the school-aged immunisation service delivers vaccinations in schools, and that is for the adolescent vaccines that the data is on here, and then they also do flu for children from reception right through to year 11. You can see again the data follows that similar trend as once we hit COVID, we're starting to see quite a severe decline in uptake. I think that's partly to do with there were lots of issues delivering COVID vaccinations in schools and a lot of backlash from parents, and we're still trying to get over that at the moment. I think the change from seeing more academies has meant that we're having to work very separately with schools rather than that overarching local authority approach that we could take previously. We have a new provider that came in September, so we're hoping that with their dedicated team that we will be able to increase uptake. We've not got published data since 21-22, but obviously we provide that data to your local authority public health colleagues so they can work with us to support the programme. Next slide, please. So moving on to adult immunisation data, on here we've got the shingles vaccination coverage, and just below that is the pneumococcal vaccination coverage. So again, very similar to those England averages, sometimes slightly higher. Shingles is a programme that is specifically designed within certain age ranges. So to try and hit the uptake, you've got to be vaccinated within a certain time period, which can sometimes be difficult. And pneumococcal is higher than the England average at 73.9. I guess we try to encourage singles and pneumococcal when we're delivering the flu programme as well, so we can do that one-stop shop for people attending for their vaccinations. Next slide, please. So this is the adult flu data, which is put into different sections of the over 65s, pregnant women, and the at-risk cohorts. So this data is showing the ICB average, Nottinghamshire, Midlands and England average, and you can see that for the over 65 that Nottinghamshire outperforms. For pregnant women, just very slightly outperforms, but needs improvement from the previous year, and the 65 at risk again slightly outperforms but needs improvement from the last year. So for the flu programme this year, we will be focusing on pregnant women, children, and the at-risk cohorts. Next slide, please. And this is the COVID data from the last programme that was delivered in spring, just for inclusivity of the uptake. It is lower uptake, but again, we are seeing the same trend with COVID that it's being less and less attractive for people to take up. And I think is that all the data? Yeah.
And then just to wrap up, thank you for the data, Sarah. I think probably worth making the point that while on most vaccination programmes we're at or above the England average, that masks quite significant variations within the county. And to go back to that mapping slide, looking at measles, mumps and rubella vaccination uptake, really significant variation, and we know that uptake in Worksop, Mansfield and Newark is significantly below where we need it to be, but it's exactly that kind of intelligence and insight that has helped us target our community engagement activities. So working in those areas, working with certain communities where we know uptake is lower, so certain Central and Eastern European communities, the Gypsy, Roma and Traveller community, for example. So we've been working to develop specific resources, having those translated into different languages, and to attend different community groups to try and work with colleagues, including GPs and other providers like health visitors, school-aged immunisation providers, to improve uptake. I think that was everything in terms of the report, and happy to answer any questions.
Great, thank you very much, and thank you for all the information. Has anyone got any questions or comments? Councillor Jackson.
Thank you, Chair. I'm from Mansfield, so obviously I'm concerned that we're in an area of a low uptake, and I'm reassured that you're doing a lot of work. However, what hasn't come out in the report is what are the reasons underpinning that low uptake? Presumably you must know those. Some of it will be opportunity and people not having the opportunity or information, but there must be something else underpinning it. Have you got to the root cause of that? Because without getting to the root cause, how are we going to fix it?
That's a really good question, and the answer is it's really complex and multifaceted, and we know that people's behaviour towards vaccination is a really complex and nuanced thing. National evidence, particularly with this decline we've seen post-COVID, there's evidence of what we call vaccine fatigue. Parents have had enough, basically. They were being bombarded with messaging around getting their kids vaccinated with COVID. You know, people just feeling that they've had enough of that sort of that call and recall. Some of it's incidental. So we're hearing from some parents, for example, that, you know, during lockdowns, when they felt that GP practices were closed, they didn't realise that routine immunisation was still being offered. So these aren't parents who've actively declined vaccination or who are anti-vax per se. It's just they hadn't realised there was the opportunity to attend appointments as normal. But some of it is really nuanced, and that's part of the work we're doing, is going out and having those conversations with families. We've had focus groups running. We've had a foundation doctor on placement with me, going out and working in a practicing workshop, calling parents whose children haven't been vaccinated to have those conversations, find out why they haven't attended, and to encourage and support them to give that informed consent. But yeah, absolutely appreciate it's that insight that is driving what we do to address it.
That's really helpful. Thank you for that answer. Thank you.
Thank you. Councillor Wilmot, I think you were next.
Thank you very much, Chair. Firstly, can I also thank the previous chairman, Councillor John Doddy, who always actually provided a fascinating chair's report at every meeting. I just wondered if you're going to carry on that, because I think it's essential that we get to know exactly what is happening in our towns and in the whole of the county. Having said that, can I thank the interim director for the report? A lot of hard work's gone on, I can see that, but there is a lot of improvement still needed, and some of the issues are quite disturbing, actually. We have plans in place and the necessary information at hand to help other organisations about ongoing surveillance of emerging threats and functions. It's absolutely essential that we get that message out. You were right that the COVID-19 pandemic brought us all down to earth with issues we never thought possible. It's very concerning that you feel that there is so many potential threats and there are the need for so many health protection measures. It is good to see so many organisations working in partnership for protecting the health of the people of Nottingham and Nottinghamshire, and it's good to see a vaccination programme is available. But what is disturbing is the fact that so many people are not using the service. You say there's been a new vaccination strategy introduced. Has this made any difference in the uptake? You perhaps be able to tell me that. I now move on to the community infection prevention and control. It seems that nationally people in care have reducing incidence of catching infections, but it says E. coli, the bloodstream infections, remains a serious problem. How are you going to address that problem? Because our elderly are very important people as far as I'm concerned, and any issue there is needs to be addressed. It says in the report that a number of partners are working on a number of problems with children's diseases, such as streptococcal infections, whooping cough, sudden attention deficit, hyperactivity disorder medication, and contaminated chocolates accidentally distributed through a market store. Well, that's an incredible situation. I don't know how that's happened. And the increase in measles cases. This, of course, can introduce the most infectious respiratory disease. I just wondered how you're combating these problems. In this report, which is a fairly good report, and there are still serious incidents taking place, and you ask how we could help. Well, I think the first thing is to put a programme of information out there in the community, informing the population of the serious consequences to their health if they do not take up the options of inoculation against these serious conditions, and also to take up a scanning programme if you think you've got a problem. I thank you, Chairman, as I say, for listening to me, and I thank for all the information that's been given. There's still a lot of work to be done, but if we all work together, I think we can do something about it. Thank you.
Thank you, Councillor Wilmot. With regards to the Chairman's report, seeing as full council was last Thursday, we thought there was not much of a turnaround to be able to actually do the Chairman's report, and following the review, I think I would like to have a look at how we look at it slightly differently. So I think that's something that I will take away, and when we do the review, we'll talk about it in more depth about how the Chairman's report can probably be slightly different, not necessarily the same, but it's something that I would definitely agree we need the information out there. It's probably how we get the information out there. I'll go over to you guys. Viv, did you want to come in first?
Yeah, thank you, Councillor, for your comments. So, I think you're right. The health protection report covers a real broad range of health protection issues that we've got, and a real testament to the team and the system actually around how we are ensuring that the health of our population is being protected. In terms of some of the specific areas that you want, I'll see if Lucy wants to come in terms of some of the specifics around the vaccination and the measles. But what I just want to provide reassurance around really is that we have a very good system that will respond to a range of health protection issues. So if it's around thinking around the E. coli, some of that will be thinking around how we reduce the prevalence of or the amount of E. coli in the population from messages around how we're cooking our food or how we're having good infection prevention control processes. It's amazing how good just washing your hands really well can do. So if there's one take-home message, it would be really make sure that we're washing our hands for the 20 seconds as we were very much talked about in COVID. But there's other areas around how we work with our health colleagues. So, how are we linking with the support around our community and our acute services and how their infection prevention control teams. So it's a really broad and complex system approach to some of these things. And I think also we do need to remember that although we're seeing numbers, we're not seeing really, really big numbers around this. So yes, we're seeing more than we would like, but in terms of the overall numbers of people having these infections, we're not seeing massive amounts of numbers. But I don't know whether I know Lucy and the team have done a tremendous amount of work, particularly around measles, and we're in a good position there. So Lucy, I didn't know if you wanted to just touch on that.
Yeah, just what perhaps worth mentioning. So people may or may not be aware, last year NHS England set up a national measles elimination plan in response to rising numbers of cases nationally, but particularly in the capital, with them projecting somewhere between 40 and 160,000 cases nationally in the next year if action wasn't taken. So every local authority area in the country was tasked with setting up their own measles action plan. And actually what we've seen is parts of the country have really significant measles outbreaks in the last 6 months or so. So our neighbours in Leicester have had quite a significant and sustained outbreak, Birmingham as well, and London numbers are continuing to increase. In Nottinghamshire, on the other hand, I'd say we've been lucky, but also some of it is by design. We put a huge amount of work in. We've seen sporadic cases. We've seen a few small clusters of cases, but no significant outbreaks. But what we've done in response to that national call to action is put together a multi-agency group around measles preparedness and response to ensure that we've got really strong action around preparing to preventing cases of measles, so promoting vaccination, but responding really promptly to cases where they arise to prevent that onward spread. So that's an area where actually we've got an example of really good multi-agency cross-working, and I'm really pleased to say, touch wood, that to date we've actually had relatively few cases locally.
And just to add to that, I think one of the things that I really want to make sure that we're really, really clear around is that our vaccination programme is really effective. And actually, many of the outbreaks that are seen nationally or locally are preventable. So the more that we can do to increase our vaccination uptake, the more we are going to, one, protect those individuals, protect our population, but also think around how we're reducing demand on some of our health and social care services. So anything that we can do collectively to think around how we further enhance, yes, we're in a good position in terms of nationally from our measles uptake, but there's still more to do. We're not achieving our 95% threshold, which we would like, which would deliver our herd immunity. So how can we push ourselves and increase our pace and scale around vaccination would be a real ask to the board.
Councillor Crosby.
I've got it wrote down. We in Newark are interested to know what initiatives or programmes are being developed to address health inequalities around screening, as we look to take a place-based approach where we already have the engagement with residents, like our Investing in Communities work in Ortonville. Officers have asked whether there is screening data at local level, and also just wondered if there is district and borough representatives on the Health Protection Board.
Pick that up. So there is some work going on around inequalities in uptake for the national screening programme. So that includes cancer screening, bowel, breast, cervical screening, but also diabetic eye screening, AAA screening, and screening for antenatal and newborn. Sarah, you might have some comments about any specifics, but I know you cover more of the immunisation side. But we've got, what I can do is put you in touch with a colleague who specifically covers Sarah's counterpart in the screening side, who can give examples of locally based interventions where we've got work focusing on inequalities. It includes things like videos for patients, detailing what the screening process involves, doing targeted phone calls to patients before their screening appointments.
Some of this information,
Sorry?
Could you email me some of this?
Yeah, absolutely. I'm not sure about district and borough representation on the Health Protection Board. I think Viv might be able to pick that up. But certainly in terms of being able to get in touch with you after the meeting to let you know what's going on locally and to provide you some of that very local level data, that really should be no problem.
Thank you so much for that. Brilliant.
I can give you some information regarding the cancer screening program, purely from an ICB perspective, and also as a GP and a cancer lead for the ICB. So for the 3 cancer screening programs, we actively look at the defaulters or screening defaulters and send things like sending reminders. I know some primary care networks have, where particularly in Bassetlaw, one of the primary care networks have employed a dedicated Polish-speaking individual to invite and get the cervical screenings and breast screening done. So with regards to the bubble screening, we actively, again, defaulters, reminders are sent. Nottinghamshire as one of the ICSs within East Midlands Cancer Alliance, we are actually above average when we compare to the other East Midlands, Leicestershire, Derbyshire, etc. So I think from a cancer screening program, particularly from an NHS perspective, primary care has a very active part in chasing the default patients who have not patients, public who have not responded to invites.
Brilliant, thank you for
that. Professor King.
Thank you very much. Just 2 quick questions. One of which I was just wondering about the data and how granular can you get, not just about place, but maybe around ethnicity or other groups as well, because you just presented very much place-based approaches, and that might enable a more targeted approach. And some lessons there. And I think, the comment just there about somebody who's Polish speaking as an example, maybe to reach certain groups as well. And the second question is around the learning that's taking place both locally about what works, but nationally as well. So what are the opportunities to bring in that learning and see what works for particular groups as well. So you presented very much in a place-based approach, but I'm thinking a slightly more targeted way for both of those things.
Yeah, really good question. So most of the performance data that's fed the presentation here is GP level data. So it's extracted directly from GP records. So it relies on the fullness of those GP records. So we tend to have pretty reliable sex and age data, for example, but ethnicity data less complete. So we've got gaps there. So less easy perhaps to make generalizations about variations by ethnic group. Or another example is language spoken. You'll find in some practices first language spoken is coded well, in others not so well. So not always as easy to target that. But I suppose that to me links into some of the questions from councillors is how we can work together, is bringing together perhaps our data and intelligence on the quantitative side with the really vital on the ground intelligence you have about your communities from knowing the areas you work with and the communities that you work with that might not be captured in a GP data set, for example. So knowing which groups and which communities are on your patch and what perhaps attitudes to or issues with vaccination and screening and other health protection issues there might be on the ground. In terms of the second part of your question, it was mentioned in the report, the NHS England produced a national immunisation strategy last year. I know in some areas, some ICBs have produced a sort of local version of that strategy. That's not something we've yet done in Nottingham and Nottinghamshire, and I know that I personally would be pleased to see us pursue locally to think about how we can take some of those national messages and lessons learned and look at how we could apply them to our local population.
Councillor Ellis, I think you were next.
Thank you, Chair. My question is about shingles. Yeah, I'm a bit older than most people. A lot of my friends, well, 3 of them, actually managed to get shingles before they were 70 when the vaccination came in. And then it was changed this year to, I think it was 68. But there was a gap when you weren't 70, so you had to wait. And then it was, and a lot of people got, well, am I important or not? Because the wife's got it, but I've got to wait another 2 years. And there seemed to be a bit mixed message with shingles roll-up. That was my basic one. And the other one was COVID. Again, with the spring COVID, I have friends that are looking after people that were they're immune deficient. And it was quite difficult for them to get a vaccine. In fact, they weren't part of the vaccine rollout. So now we come to this time of year and they've caught COVID and the people that they were looking at are now susceptible through there or they can't get the care. It just seems that that the numbers that were COVID was aiming at was less, but we've taken that herd immunity, the people that were close to them that could have done with a vaccine were told, no, you don't need it. And now we seem to be reaping the benefits on this recent COVID strain that's come out that seems to be quite dire to people that have caught it. So I'm just wondering whether the winter COVID stroke flu that we normally get will be a bit more broader based.
So Sarah, I think, might be able to come into this. I think probably worth pointing out that the decision about which groups are and aren't eligible for different vaccination programmes, including age cohorts, that's the decision taken nationally by the Joint Committee on Vaccination and Immunisation. So the age range for shingles vaccination, for example. So as much as we might want to increase that either side of 70 to 80, actually the sort of national service specification means that GPs are only commissioned to deliver for that population that's been set at national level. So that's just to give that bit of background. Sarah, I don't know if you want to talk about who the COVID cohorts are this season.
Yeah, so as Lucy said, it's dictated from the JCVI, so not even NHS England. We take advice from the Joint Committee of Vaccinations and Immunisations, and obviously it's based on risk, and it will be based on cost as well. And so it was a very pared down programme for spring summer. We're still waiting for the cohort information for the autumn winter programme. So we are expecting it will be a broader cohort than the one that we've had for spring summer. But we've still not got that information. But I appreciate what you're saying. It is very difficult when you're caring for someone that's severely immunosuppressed, and you're wanting to protect them as well as yourselves. And with shingles, we've had that feedback a lot. There is now an eligibility calculator that practitioners can use to make sure that they are vaccinating the eligible cohort. But yeah, you could be living with somebody, you're eligible, they're not eligible. But again, it's just about that rollout and the guidance that we get from JCVI around who should be having it and when. And a lot that's to do with, your susceptibility, how long the vaccine lasts for. So, because vaccines do wane, so we just need to give it at that optimum time to provide the best protection.
Thank you. Councillor Gowland.
Thank you. So first of all, I'd like to welcome you as the chair, and I think it's probably good to have a non-clinician. Actually, it brings a different perspective. I'd just also like to say the chair's report, it did become a bit of a litany of good news stories, which I'm not sure are terribly helpful. Good things shared, good practice is good, but just all the good news isn't necessarily helpful. But coming to this report, I won't talk about the vaccination programme, because I think it's been absolutely one of the best reports we've had in the health scrutiny health wellbeing since I've been on it. Seeing the data, actually being able to understand it. I've heard calls for seeing more granularity for Nottinghamshire would be really helpful, but I appreciate it's a lot of work, but it would be really useful to be able to see that. I just wondered why some of the age 1, for instance, some of the age 1 vaccinations, people seem to have one vaccine but not another. It seems slightly hard to understand, but maybe there's a detailed story to do with how they're called for those vaccinations. I also wondered why there's no data for Nottinghamshire on the diabetic eye screening. I'm sure there's just a good reason. And also, finally, I wonder if it's possible to specifically get the mapping for DO1. We haven't really talked about this, but the air particulate mortality across the county would be really useful. Thank you.
Thank you. All really helpful questions. What I'd encourage councillors, all colleagues to do, if you've got a specific query about a specific programme for a specific area, please do feel free to get in touch with the health protection team. We've got a generic inbox, and if you've got queries about the data down to practice level within your particular area, we can supply that on demand, rather than, I guess, trying to put that really comprehensive picture into the entire report. But very happy to follow up if you've got those specific queries. With the diabetic eye screening, I think that's because the annual data wasn't available at the time the report was compiled, but again, we can follow up with that as needed.
Thank you. Victoria, did you want to come in earlier?
It kind of was covered a little bit, but I think there's a real opportunity, isn't there, with place-based partnerships to bring people together to do that design of what would work best within those local communities. And I think we've all expressed a really strong desire and appetite to really accelerate that kind of way of working. And I think there's a lot more opportunities for us to take key challenges that we've got. Immunisation and vaccination is critical, isn't it, to our future health and wellbeing, a really important part of our entire prevention agenda. And I'm just thinking from a health and wellbeing board perspective, it'd be really good, I think, to hear from place-based partnerships a little bit more about what are those things that we can do by coming together that really bolster and enhance the work that colleagues have articulated earlier.
Thanks, Victoria. And I can probably just make a comment on behalf of Mid-North Place-Based Partnership, and I'm sure it's the same for South and Bassetlaw as well. So screening and vaccination is a priority, whether it's a Best Start scheme or something which is equivalent in the place-based partnership. So it's definitely, for example, in Mansfield, there's a separate project where we've identified pockets of poor uptake and very targeted approach to get those children in to get the vaccinations, and it's actually part of the HIF or the Health Inequalities Fund. So there is some very specific. So maybe on a future day we could probably address some of the very specific place-based partnership targeted interventions. I was also going to come with a couple of comments, particularly to Sarah. Actually, when we look at the providers, but school age immunization providers, it's independent of primary care. So I'm a GP by background, so I'm partly culpable for some of the poor uptake as well. But in terms of doing so, as you can see in general, through primary care, like in September, there is a lot of activity in primary care to get patients coming in for the flu vaccination, COVID vaccination, also childhood immunization. What I see as a GPs on weekends when we do have it, we do have lots of teenagers, kids bringing their parents, their grandparents coming to get the vaccinations done. And I wonder whether there's an opportune moment there while they're there with their nan and getting them done, whether we could start identifying, because Nottinghamshire as a system, we are very good in our data to identify where the deficits are or where the uptake is poor. So I know it's a national thing, but whether we could try, if there is an appetite to look into some specific pilots where we could look at a slightly different approach in addressing particularly the school, because I think when I looked at the data, I mean, along with pregnant women, that really is an outlier in terms of the uptake wise, and because in terms of herd immunity, that's a group of population which are very communicable in terms of spreading things around. So we definitely want to target that. So maybe something which you can take to as NHSC to see if there is some an approach there. We could try the pilot and see what it is. And particularly in September, when there's that focus and the messaging is there, we could have a consistent messaging across all age groups, just trying to bring everyone in. And while they're there, you can just jab them. Thank you.
Yeah, absolutely. And GPs are from any child from the age of 14 can be vaccinated by their GP for their adolescent immunisation. So you could do that opportunistic vaccination while you've got them there. But happy to look at doing a piece of work on that if you think that that's not clear to GPs, that they can be part of the school-aged vaccination programme.
That would be helpful. Thank you.
No, thank you. Councillor Ellis, do you want to come back?
Just a quick one. Used to be that when you took your child for your polio, that the parent also got the sugar lump as well, like while you're here, mum. And it was done then. So it's going back to that approach, isn't it, to find out exactly who in the surgery has been vaccinated, and while you've got the needles ready, that the uptake could be there.
I completely agree. I think it's what we'd call our making every contact count approach. It's that opportunistic thing. Once you've got people in front of you, that might be the only time they cross the threshold of the practice if they're generally fit and well. So taking that opportunity. I know in the area that I worked in prior to coming to Nottinghamshire, the GP practice had developed a template so that when a parent called up to book an appointment for their child, didn't matter what it was about, a pop-up would come up and automatically tell the receptionist every vaccine that they were outstanding. So that was an opportunity there and then to book them in for vaccination. So these are the kinds of approaches we could trial on a quite local level or a sort of place-based level initially, but there's lots of things we can do on a practical level to try and identify the children who are outstanding doses and then get them in. But I agree, I think that opportunistic stuff and grabbing mums when we've got babies in, I think it all helps.
No, thank you. I think anything that we can do to increase the uptake, and like you say, make every opportunity count. Recommendation 2 is to see how we can increase vaccination and screening uptake. So anything that we can do with regards to that would be really helpful, I think. And I think GP practices, when you've got them, get them as such. Right then, if there's no one else, shall we take a vote on the recommendations on the report? Everyone in favour, please show your hands. Thank you very much. So now we move on to agenda item 6. So next on the agenda, we've got a report seeking approval of the Joint Strategic Needs Assessment Profile Pack on community-centred approaches to health and wellbeing. Before I hand over to Catherine McVicker to introduce the report, can I have someone second the recommendations, please? Thank you very much. So Catherine.
Thank you, Chair. I'm Catherine McVicker. I'm one of the specialty registrars in public health at Nottinghamshire County Council, and I'm really pleased to be here today to present the JSNA chapter on community-centred approaches to health and wellbeing for board approval. The slides that Lizzie is kindly presenting for me are going to run through some of the overarching themes and key recommendations in the JSNA. Next slide, please. So to start off with, it's important to recognise that the term community can mean different things to different people. Communities are groups of people joined by a common interest, characteristic or experience, and this can be defined by many things such as race, health need or faith. But this chapter focuses on geographical communities, so those defined by place. Community-centred approaches focus on mobilising communities' own resources and assets, promoting equity and increasing people's own control over their health and lives. And we know that partners across the system in Nottinghamshire are undertaking substantial work programmes linked to communities. So the purpose of this Joint Strategic Needs Assessment chapter was to try and create a shared local understanding of the evidence of effectiveness for working with communities to promote health and wellbeing in order to support that ongoing work and enable consistency across Nottinghamshire. Next slide, please. So within the chapter, there is an evidence review which summarises the literature on community-centred approaches to health and wellbeing. And some of the key findings from that are that community needs differ and there is no one-size-fits-all approach to community-centred initiatives. So needs are best defined by communities themselves. Emerging evidence suggests that community-centred approaches can improve wellbeing, social connectedness, can reduce social isolation, reduce social care demand, improve physical health, although the quality of evidence in this area is quite variable for a number of reasons, such as some of the challenges in the long timescales needed for some of these initiatives, as well as some of the challenges in demonstrating impact for some of the outcomes which are perhaps a bit less tangible. Additionally, the JSNA chapter has a summary of some of the local insight that's been collected by system partners across the county about what is important to communities. And some of the themes from these findings are that communities want to be supported and involved in their own development and feel that organisations are working alongside them, and that communities want creative and flexible solutions to services and funding that can adapt to communities' ongoing and changing needs. In terms of what the findings in the chapter can tell us, just to kind of touch on a few of these things, one of the key challenges experienced in this area is around funding, and for community-centred initiatives, funding is not always long-term or sustainable. The importance of community voice is increasingly recognised across organisations, which is really positive, but some communities are experiencing consultation fatigue, which needs to be recognised. Next slide, please. There are 11 recommendations in the JSNA, which are for any organisation working with communities, with key partners recognised as the County Council, district and borough councils, place-based partnerships, and the community and voluntary sector. The slides don't cover all 11 of these recommendations, but I've picked out some of them for the next two slides. So organisations in Nottinghamshire should try and work together to develop a structure for coordination, communication and strategic planning for work with communities, including sharing and responding at a Nottinghamshire level to relevant insights and issues from community forums or networks. As far as possible, work with communities should build on existing assets and resources and be led by people living and working within the community, trying to avoid a top-down or kind of one-size-fits-all approach. And in working to embed community engagement and co-production, organisations should ensure that they always review and consider all existing engagement and insight prior to seeking new information, share insights with other organisations where that's consistent with confidentiality, and feed back to communities on how their views were acted on, or if that was not possible, why and what was done instead. Next slide, please. Organisations should prioritise stability and sustainability of work with communities, particularly in terms of funding and staffing, and be mindful of the impact of short-term funding cycles on small organisations in particular. Organisations should be mindful of labelling and language used when talking about or with communities, trying to use asset-based language rather than deficit-based language, and linking in with language around the building blocks of health and with strength-based approaches used in adult social care and elsewhere. And finally, those planning to work with communities and support community-centred interventions should ensure that evaluation of the programme is embedded throughout, trying to take a proportionate approach and using measures of success appropriate to the aims and principles of community-centred approaches, and also good practice regarding evaluation methods for these kind of interventions should be shared across the system to try and inform future evaluation planning. Next slide, please. So the ask of the board is to primarily to approve this chapter, but also to share and endorse these recommendations. So thank you for listening. I'm happy to take any questions, and I'll hand back to you, Chair.
Thank you for the information. Viv, do you want to just come in?
Mine was a question, really, Chair, so I'm quite happy to wait if that's helpful. So thank you very much, Catherine and Dawn, for the work that you've done this. I think one of the things I'm really keen that we're doing with the Joint Strategic Needs Assessment chapters is to really start thinking around how we're opening up conversations that are much more system focused. And I think this is a really good example, and I think the next one around adult social care prevention and equity will also help in terms of that. But one of the things I think you've really highlighted really well there is around that there's loads of great work going on across Nottinghamshire, and that we are supporting, and we have some really strong communities in a range of different ways. But there's something around that strategic approach, and absolutely acknowledging that this needs to be a bottom-up grown approach that is absolutely people-led, as you mentioned, and really co-producing that, allowing that local flex in the communities. But I do also acknowledge that we're all doing different bits that aren't necessarily joined up, that are duplicating. There's a lot of discussion around sustainability and stability, and I just think, is there a way that we can collectively come together and think around potentially taking some of this conversation into a slightly different form to maybe bring something back to the Health and Wellbeing Board around how do we strategically think around how we support our communities in a different way in Nottinghamshire, acknowledging that there's broad work going on across an ICS situation, ICS footprint, but really embedding that evaluation approach. Because I think one of the things that you highlight there is that there's lots of positive things coming out, but we haven't got the evidence base as strongly in this area, which probably links to some of that sustainability and stability argument there. So how can we turn the curve on that, allow things to grow, but also make sure that we're embedding that evaluation for that longer term approach?
Thank you for that. Councillor Crosby.
Thank you, Chair. Right, wrote down again. Will there be conversations to expand the Investing in Communities work the public health have funded through the CVSs, and who is going to be leading on this work, considering recommendation 1 stating organisations should develop a structure to coordinate this work, capturing local insight?
I'll take that one if that's okay, Chair. So I think what Catherine and the team have highlighted here is that there's a range of things that we need to consider around in our community approaches. I think what we do have to acknowledge is that there are some areas of community funding that has been supported through the COMP funding, so funding that we specifically had around COVID response and preparedness. What we are doing, and Dawn will be able to give us more information on that, is evaluating some of those approaches to really understand what impact have they had, to then think around what do we want to consider in the longer term, because we have got a defined budget, and we will have to consider, there will be difficult decisions to make, and I don't shy away from that. But certainly we feel within public health and across the council more collectively that we know that we want to do more things with our communities. Certainly there's a lot of discussions, and I think some of the movement that we've had with public health moving into the place department within the council puts us in different opportunities, particularly around our communities work. So all of that will come together around that, but I acknowledge that's only the council's offer, and actually there's a range of offer around this table, and that we're only one bit of that puzzle. So I think there's something around getting our own house in order and thinking around what our longer term vision is, but collectively thinking around how that's one piece of a much bigger puzzle. And I'd be keen to think around what other partners, how they see that fitting as well.
Thank you. Helen, did you want to come in?
Thank you. First of all, a big thank you for this chapter, because it's something that South Notts Place-Based Partnership asked for through the prioritisation route. So thank you. And also to acknowledge the group that you had involved in developing the chapter was a real broad range of colleagues with experience. So just wanted to highlight that as a really good approach to this. I think what we've found from working across South Nottinghamshire, and particularly some work that we've done in Killistic, is actually you don't need loads of money to do this kind of work. And actually, from an NHS perspective, not going in with a service view and not doing that doing to thing has been really helpful. So bits of seed funding that supported a breakfast club that's now been sustained through the local church. There's different ways of doing this once you work with communities to identify the things that will help them. So I think just to really highlight that we're not looking at service solutions in this area of work. And also from a South Notts point of view, we've used the recommendations already to check in with our integrated neighbourhood working approach and highlighted bits that we need to do better. And I think language is one of the really big things, because we all slip into our organisational language rather than thinking of plain English. So I think it's really helped us focus in on areas that we need to work better on. So thank you.
Thank you for that. And Councillor Walters.
Yeah, thank you, Chair. Just to clarify something from little old me, what is asset-based language? Is that some positivity, negativity slip thing? Could you please explain that?
Yes, of course, and sorry for not explaining that as I kind of went through the presentation. So I think that's about how we're framing things when we're talking about or with communities. So rather than kind of focusing on where there are gaps or kind of challenges and framing things with a sort of negative lens, it's really trying to draw on the strengths and capabilities that we do know that communities have. And obviously we recognise that in some situations and for some settings, that's not always possible, because sometimes we do need to kind of look at need in a different way. But I think where we can, really just trying to acknowledge the strengths that communities have and use language sort of appropriate for that.
Yeah, well, thank you for that. I'm going to add it to my NHS terms and definitions. Thank you.
Thank you. So just to add on to that Catherine's provided there, when we speak with communities, what we hear back is that communities don't want to be viewed as deficits or index of multiple deprivation. So I think this also chimes with what we hear when we're engaging with communities. Obviously, if we think of our own experience in life, we want to think about our strengths and our resilience and our pride. And I guess that's what we hear back as well. So we need to be really careful about our language, because we often go in with this lens of where we need to address need and where we need to support and help. And actually, what the JSNA is showing us is that both our communities and our evidence show that that's not necessarily the most helpful approach when working with our communities. Thank you.
Thank you for that. Victoria, did you want to come in?
Thank you. Just to reinforce the point that they've made, really, and I couldn't agree more with the real ambition that we've got, that this is a really good chapter and really welcome, and thank you for all the hard work that's gone into it. I don't think we'll ever get to a point where we've got absolutely, gold standard RCT type evidence of something that works. We don't live in hermetically sealed environments where nothing influences and there's no variation. So I think intuitively everybody in this room would probably agree that working with our communities and supporting our communities to thrive and develop solutions for themselves is the right thing to do. So I'm kind of very confident that what you've articulated in here is the right direction of travel. What I'm really keen to do is not fall into the usual trap that we often have from a public sector point of view, because we're really good at writing documents and really good at putting things on paper and having really good ideas, but we never really do that full transition into, so what difference has it actually made, which is where I think we really need to get into. So I think there's an open invitation there. We are really up for that conversation to think strategically, how do we collectively create the conditions for success for those communities and don't get in people's way, really, where we don't need to. Because inadvertently, I think we do that sometimes. So I think for me is so what's next? How do we tangibly take this and future chapters that I know that we're going to be doing as well? How do we really, really make this work and make a difference for local people? I'm really up for that conversation. I think Viv is as well.
Thank you for that, Victoria. And I think just this morning at Councillor Walters, I'm not sure if you're aware, there's the opening of the Ashfield Community Hub, which is probably a very good example of what this is actually in action, although that's very specifically looking at the social prescribing link workers and access to social prescribing, and it was Ashfield Voluntary Action Group, everyone active, Ashfield District Council and social prescribers getting together to develop a community-based asset or community-based strength. So very similarly, so it would be interesting. I think there's 3 or 4 examples here of other similar interventions. So what Victoria said, I agree. I think we all agree that the partnership working, place-based partnership, and bringing all the other organizations, voluntary sectors, how do we link in and use this recommendations to translate that? Because we've got some very good examples within Nottinghamshire, but there is that bit about how do we scale it up and make sure it's adapted across, so there aren't again some inequity in this sort of provision where there are some who are really proactive and have established this and others haven't got. So I think there is something a bit about when with the next report, maybe we need to just identify this sort of good practices, highlight it, and then showcase and make some recommendations on how it could be adapted in other areas.
Thank you for that. Professor King, I think you're next on my list.
Thank you. I thought this was really excellent. There's lots of the stuff in here, and I really like the assets-based approach, and I really like as well what you're saying about feeding things back to the communities that pass off as well, because too often that's a common concern and things. So in principle, lots of great stuff, but a couple of things just to challenge and maybe push a little bit further. I think I'm intrigued by the idea that communities have a common interest, and I wonder whether they do have a common interest. And actually, maybe there's a little bit more nuance, and there are communities and there are multiple different groups, and maybe sometimes they don't all share the same set of interests. And there's a lot of language in this about shared, say, almost like we've all got the same perspective, and maybe we don't, and maybe there's power differentials as well. And I don't think power is acknowledged in this, as in ultimately you've got slightly different power relations to the communities themselves. And there's 2 ways of doing this. Jointly working towards something is one way, but sometimes it's also recognising where the power is differently held. So I would push a little bit to think a little bit more about the nature of power in this situation. Maybe sometimes it's about being honest where the power lies, and it isn't always shared. There is sometimes differences. And I wonder whether sometimes as well there are different interests or different perspectives, or maybe there are conflicting points of view. And what do you do with conflict? This whole approach seems to be written for the assumption that if only we talk enough, we'll get to a common interest. And I wonder if that is true, or whether there are different perspectives at work. And what do you do when those different perspectives rub up against each other? And how do we settle it? And maybe ultimately, people in public health or NHS maybe have a different set of power and assets and experiences to other people as well. So what happens in those when we don't all at least perceive we have a common interest? So just have to push that as a slightly different perspective, because I think 95% of this I think is brilliant. I just wonder as a push back against that unifying assumption.
No, thank you for that. I think to your first point around the kind of common interest, I think, and perhaps that's sort of how I've articulated it today or in the report, but I think it's important that was around the point that communities can mean different things to different people. So for some people, their community will be defined by a common interest, but recognising that's not the case for everyone, and actually for some people their community is defined by where they live or by a characteristic that they have, rather than it necessarily always having to be a common interest. So I do definitely take your point on that. I think around what you were saying about power, I think that is a really interesting kind of argument in all of this, because I think that is something that came out in the evidence, that actually whilst we've said there are challenges in having strong evidence in this area, some of the evidence was actually that the community-centred approaches work best where power is best devolved to communities, and kind of they're given full kind of control to define their needs and approaches that they're addressed. But I think, as you've said, some of the findings that did also come out in some of the kind of case studies and reports were that actually if that sort of power is not, if we don't think about that carefully, then it can lead to kind of conflict, particularly in timescales, if we don't give communities long enough or these approaches long enough to really kind of develop. So yeah, I think you're right. I think that's a really important consideration in all of this. Dawn, did you want to comment?
Brilliant, thank you. I think it raises a really important point because there can be, I suppose, a degree of naivete about assuming that when you're going out to connect with communities, one, that you are achieving a kind of power balance there, that communities are enabled and empowered to express their needs and their goals, for example. What's the power dynamic with yourself as a county council or other partners? But also that there are power dynamics within communities. So some communities may feel a stronger ability to have their voice shared, will be more vocal and put themselves forward, whereas others won't. So I acknowledge that completely. I think it's something that around the room we all need to take note of and grapple with in our and become more skilled and more sophisticated as we grow together as a partnership in how we work with communities. Particularly really getting the voice of communities heard and at the centre of things, and recognising that that voice can be diverse. So I'd welcome in our journey on this partners around the room helping us build that understanding picture, including yourself, Professor King. I know you defer to your expertise in this space as well. I just wanted to give a couple of examples that play into this. So one of the things that we have found in some of our longer term engagements with certain communities, such as Bellamy, the importance of taking that time, as Catherine has said, to allow relationships and trust to develop, particularly where communities may feel left behind or let down. So that is an aspect where we need to go into this eyes wide open, that some of this work does take time, effort and dedication. So that and then plays into the question about how do we start to think about sustainable offers of funding and support across our system. The other aspect I would highlight is marginalised voices. So you'll be aware of the Director of Public Health's annual report around severe multiple disadvantage, and I think that's one example where it's so important to hear the voice of lived experience, particularly for people who are maybe marginalised, have experienced particular traumas and disadvantage in their lives, and how we ensure that we can enable those communities both to have their voice heard and to be empowered and enabled, is all part of an important challenge for this board and all our partners, in our view. Thank you.
Thank you for that. Councillor Wilmot.
Thank you, Chair. I fully support this and approve the joint strategic needs assessment on community-centred approaches to health and wellbeing. And I mean, look at the evidence. It says it's essential to create a shared local understanding of the effectiveness for working with communities to promote health and wellbeing, and to strengthen ongoing work and enable a consistent approach across Nottinghamshire. A partnership approach should always be used when dealing with communities. It makes them feel wanted and the work that they do appreciated. It is true that communities have different needs, we all know that, and need to be supported in the work they do. Some groups have great ideas and only need financial help. And finally, it is essential that all partners contribute together so that the community teams feel wanted. Now, you talked a little bit about duplication, because there is a number of recommendations being delivered by a number of partners, and that can be a problem. So how are you going to keep the communities informed on how you are delivering the priorities and recommendations in the report? Because it's a lot of bringing things together, and it's essential that that's done. I just wondered how you're going to make sure that the communities are involved and know what you're actually doing. Thank you.
Thank you, Councillor, for your comments and question. I think, as you said, a lot of the recommendations in this report are really around partnership working and making sure we are sharing understanding, partly to avoid duplication, but also around some of those other recommendations, such as evaluation and making sure we're sharing kind of in what's working. I think what you've said around making sure that we're sharing, I guess, what we're doing in terms of this work and all the other work that we're doing with the communities themselves, is really, really important. And I think that kind of links back to one of the recommendations in itself, in terms of feeding back to communities on where we are able to act on what they've told us, and if we're not, kind of why not. So I think, whilst I probably can't give a clear answer to your question at the minute, I can assure you that obviously if we act on these recommendations and make sure that all partners are working together to coordinate what we're doing and feeding back to communities in that, then sorry.
Viv, do you want to come in?
Yeah, so if I can just add to what Catherine said, thank you for that, Catherine. I think there's something around one, communicating with our communities what is going on in their local community, and I think there's something around all of our roles in that, because we all have a different lens that we can put on that, and we can all champion for our communities in different way. So I think there's one thing around that ask of us in terms of how we take out some of these actions out into the communities that we serve and that we work for, and really have that very local approach. So there's something for us as individuals, I suppose, there, and how we link into our own professional networks at that very local base. But I think there's also some work that we can do around the broader health and wellbeing board review, and it links into the chair's report and the conversation that we've had earlier around how do we share that best practice across us as a partnership, and how do we make sure that we're all aware of all the great things that are happening. And so I'd be really keen to pick that conversation up in terms of how you think that we should do that differently as we move forward, because I think we as a health and wellbeing board have a role within this room, but we also have a role around how we communicate outside of this room, and I think there's ways in which we can think about that slightly differently. So if I may, I'd be quite keen to think around how we can pick that up as part of the health and wellbeing board review, if that's okay, and if people are in support.
Totally agree with you, Viv. I think there's a way of communication and how we work as a board is something we should really discuss, and how we move things forward in a more positive way across communities. Councillor Wheeler, I think you were next on.
Yeah, I was just going to reiterate what Helen said earlier, actually, because I think Killiswick is an excellent example of best practice in terms of how all the different partners have come together. The brilliant thing about what we've been doing in Killiswick is very much people led. It's grassroots up, and I'd love to see Killiswick being used as an example for the rest of Nottinghamshire as a case study, if that was possible, because the work that's being done there is absolutely phenomenal in terms of engaging with both children and young people and adults as well. We've engaged with both the youth service, with all the different community organisations, voluntary sector organisations, and we've done that on not a lot of money, to be honest. We meet regularly, we discuss things regularly, and the key thing behind that is the people in the community are the driving force behind trying to tackle the issues around health inequalities. So I think this is an excellent report, and I fully support the recommendations moving forward. Thank you.
Thank you for that. Anything that you can feed back in as best practice would be really helpful, and maybe as part of the review we'll discuss that further, if that's all right. Councillor Tidwell. No, thank you for that. There's no one else left to speak, but I just wanted to say one of the oh, sorry, Penny, 1 second, I'll come back to you. One of the examples is Vibrant Warsop, and I'm the Warsop councillor, and I don't think anything happens in Warsop without Maddie from Robert Warsop being involved and the community being involved in some way. And I think it's so important to have those local people helping local communities and how we feed into it. So I think it's really that's a definite people-led, listening to what the population wants and moving forward with it. So I think that's a really good example to have in the pack. Councillor Garland, did you want to come back?
She's slightly picking up on that point because we have our Maddie in my area. In fact, we have a couple of them. But I was going to ask, are the volunteer peer roles sort of aspirational or are they actually now? Because I'm aware of those people in my community and I'm not sure they have a role in health. Going back to the previous report, you can imagine the community groups and community advocates talking about vaccination programs. Is that what you're thinking about? I really liked what you said, Victoria, about action and way we can move this into, because obviously we have the councils have a lot of links with community groups who are already really embedded in the communities, and so there's a lot of opportunity to make this happen. I think it's a very good idea, but I've just wanted to understand the volunteer roles more.
I mean, I can cover a little bit on some of the volunteer roles that I am aware of, but I think there are a range of volunteer roles in lots of different guises, and people are volunteering that wouldn't even necessarily call themselves volunteers. They're just doing it because that's what they think is right for the community. So I think certainly from a public health point of view, we work with our communities team, and we have a range of health and wellbeing champions, and there are a range of local area coordinators. There's 10 local area coordinators in the patch, and there are also some work around community friendly knots, and some of those are more connectors. They also align with some of the social prescribing roles, but I think one of the things that I would say is that that's just the tip of the iceberg. We've got a range of voluntary community sector organisations that have an absolute plethora of volunteers, and I think I wouldn't be doing them justice. Is the honest answer. But what I'd be really keen to do is think around is how we can have a bit more time around this conversation if the chair is and the board is happy to consider that, because I think there is something around where do we want this space to go. So we've got a really good grounding here with the JSNA chapter, but taking Victoria's supportive challenge, and I appreciate that, thank you, is around the so what. So how do we move this forward? How do we make sure that we make those connections that we're talking about, and how do we really think around how we capitalise on some of the great work, but think around how we increase in pace and scale, as you were talking around there, Tillen. So it might be something that we just might need to think around around how do we have that space, and have we got the right partners around, or would we want to extend that out a little bit wider as well?
No, totally agree, and I think it's a conversation we can have in the review moving forward about how we move those conversations and who we invite to them. I'm conscious of time because we're running slightly behind. So if everyone's happy, can we all vote on the recommendations on the report, please? Is everyone happy with them? Yeah, brilliant. Thank you very much. So, like I say, we are running slightly behind schedule. So, agenda item 7 is the approval of the Joint Strategic Needs Assessment Profile Pack on Prevention and Equity in Adult Social Care. Before I hand over to Katie Ball, can I have a seconder for the recommendations, please? Thank you very much. And I'll hand over to you, Katie.
Thank you. We're really pleased to be bringing this JSNA today, and it absolutely goes hand in hand with the item that we've just discussed. We actually think that we might be the first place in the country to do a prevention JSNA chapter, prevention and equity in adult social care. The reason that we've done this is that we wanted to build on the prevention that already exists within adult social care and health and across our system, but to understand better the national and local evidence base, because there's not as much evidence around a range of interventions in the adult space as there is in the more pure health space, or certainly in the children's space. So it was really important to us to, although we know so much about prevention, we've just been talking it for this whole meeting, it's in national policy, all of our local plans, and we're doing lots of things that are preventative. but we really want to turn the volume up on that. So it was really good to do a JSNA chapter. We want to build on that, to give a bit of context. We want to build on that to create an adult social care prevention strategy. So we're not going to try and repeat loads of the good stuff that's already in existence. Like we've got a technology-enabled care strategy, lots of work with our carers that's been co-produced. I've just a couple of weeks ago been in a really big conversation with lots of people and workforce around mental health, for example. So we're not going to repeat the good things that are happening, but we might make some more recommendations into those about where are the best places to turn the volume up further on prevention. But we also want to look at the gaps and understand it. And there's a question for us of, if we had no more resource, could we move things around, and where can we turn the volume up? And if we did have some more resource, how do we take some evidence and go and have some really good conversations with our communities through the right partnerships to make some of those joint decisions about where are the best places to use it and in the right ways? So that gives the context of why we wanted to do this work. So I'm really pleased to share it, and Lucy's going to talk through that for us.
Hi there folks, yeah, it's me again with this. So Lizzie, are you okay to flick us on to the next slide here? So Katie's given a bit of the background there, hopefully people can see that. So the Care Act 2014 places the duty upon all local authorities to prevent, reduce or delay a person's need for care and support, and the focus really is on being proactive and deploying early intervention to support people at the front end rather than just providing intensive care or support later on when people approach crisis. And as Katie mentioned, we think we're the first area in the country to undertake a full JSNA process to try and describe our local need for adult social care, what the local sort of risk and drivers of adult social care demand are here in Nottinghamshire, but also look at the evidence for promising preventative approaches we might want to invest in as a system to reduce, prevent and delay people's need for social care. So the JSNA, I just want to acknowledge, was led by an external consultant, Dr. Kate Carmichael. She's a Director of Public Health by background, so she led the work up until May of this year, but supported by colleagues from both adult social care and public health. So Katie leading from a social care perspective and me from a public health perspective. And as I said, it's a two-parter really. So the JSNA analyses, first of all, a range of intelligence and evidence looking at our local need and challenges facing our social care sector locally. So what are our sort of current and future drivers of need? And then trying to look at what the evidence base is and where there might, as Katie said, be gaps in the evidence base for what works from a preventative point of view. Next slide, please, Lizzie. So we talk about prevention a lot. People have got a broad understanding of prevention, but in the social care context, it's about helping people to stay healthy, happy and independent for as long as possible. And as I mentioned before, it's about reducing the problems of chances arising in the first place, but where they do arise, supporting people to manage them as effectively as possible. Next slide, please, Lizzie. So don't tend to go through the findings and recommendations in exhaustive detail, but just wanted to draw out the key points. As you might expect, the key and main driver of social care demand in Nottinghamshire is and will continue to be our ageing population. So we've got an increasing number in absolute numbers and proportion of people over 65 and over 85. Wanted to highlight some work that we've found here, but in other analysis, that actually healthy life expectancy, so that's the proportion of your life lived in good health, is going backwards in some areas, but particularly for women. So that while women live longer than men in number of total years in Nottinghamshire, they live more of their life in ill health. So actually it seems to be women's poor health that's driving a lot of our social care demand. As always, talk about the building blocks of health. We know that the places where people live, their homes, their neighbourhoods, communities, can affect their health and well-being, and in turn their chances of needing social care support. So flicking on. So range of personal health issues affecting quality of life and independence, and disability is a big predictor of social care need. We know that the number of people living with long-term conditions and disability is projected to increase in Nottinghamshire, so that's likely to be a driver of future social care demand. But importantly, those are things that are preventable, modifiable or treatable. So from a prevention perspective, what can we do with major conditions like stroke and heart disease, for example, which are major causes of disability locally? In 2021, nearly a fifth of our total adult population had some sort of limiting long-term illness or disability, so really significant proportion of the population. And we also want to highlight the impact of what we call multi-morbidity. So that's people living with two or more long-term conditions. We're seeing an increasing number of people living with multiple long-term conditions. And in particular, we wanted to highlight the gap between our most deprived and least deprived communities, because there's a huge health gap there, particularly again for women. So for men, the age at which you experience your first long-term condition, the gap is 8 years for men living in the most affluent and most deprived communities, but that gap for women is 15 years. So if you are living in the most deprived parts of the county in Worksop, you can expect to have your first long-term condition diagnosed 15 years before a woman living in West Bridgford. So really significant disparities there, and likely to be a result, like to have an impact on variation in social care demand across the county. Next slide, please, Lizzie. So I've mentioned we've got an increasing number of adults under 65 living with disabilities, but that's partly driven in particular by the number of people being diagnosed with learning disabilities, and thankfully now people with learning disabilities living longer than they once did. We've also got, as a major driver of social care demand, an increasing number of older people living with frailty. And we know that nationally frailty is the number one predictor of formal social care costs. So actually we need to do something really significant about our approach to our increasingly frail population if we want to do something about social care needs. Big variations in frailty again across the place, with Mansfield and Bassetlaw having the highest rates of frailty in the adult population. As well as all the stuff related to physical health, some of which you might think is quite intuitive, there's also some really interesting and emerging evidence around the impact of loneliness and social isolation on social care need. So actually we've got over 20% of adults in Nottinghamshire reporting feeling lonely, sometimes, always or often, and almost 30% of adults over 65 living alone. And again, that's likely to be having an impact on our social care needs. So it's not just people's physical health that we need to be mindful of. Next slide, please. So that was the sort of picture, that's what's driving social care demand. In terms of that next bit of the piece, so what works, what kind of approaches look promising for preventing or reducing need for social care. Well, as Katie hinted, that the evidence base isn't huge, and what evidence there is isn't hugely robust, and a lot of it comes from the health sector rather than the care sector. But where we do have some promising sort of emerging evidence is around developing effective information advice and guidance approaches, so particularly at our front end. So when people get in contact, for example, with our customer services centre, how can we make sure we better connect them first time round to the right sources of support to prevent their need increasing or escalating further on into the system. Working around strengths-based social work and approaches, work around re-ablement, social prescribing, and keeping mobile. So lots of work around falls prevention, for example, looks really promising for reducing social care need. But all of those recommendations are there in full in the report. And I think that was it, potentially. Oh yeah, just a few notes about evidence gaps. Well, I've mentioned that we've got an increasingly ageing population. What we haven't got, and I think this is a national picture, really reliable projections of ageing and healthy life expectancy are more difficult to come by. So that's something that, as part of the next phase of developing the prevention strategy, we might look at, is trying to get a really good handle on what our future care needs are going to look like if we carry on at the current trajectory. And we also want to understand a bit more about our local picture, the risk factors for things like frailty and multimorbidity, and inequalities within Nottinghamshire for things like multimorbidity and frailty, so that we can better target what resources we do have to make sure that we're taking an equitable approach. But Katie, unless there's anything you want to wrap up with, I think that's about it for there.
Thanks, Lucy. And I think, I'm not sure if you'll have read the entire chapter, you might have done, but there are some things that start to come out in terms of differences across our geographical populations across the county, as well as some themes about specific issues. So, for example, people with mild cognitive impairment, like my dad, there are lots of things that you can do
that help to slow or even reverse some of that. So he has his two daughters ringing him every day, checking on, have you, can we get you out, and some of those things. But actually, to drill down into some of that information and join up with lots of other things that we're doing, so that we could possibly have conversations with lots of groups that are already happening in communities and share some of that deeper information to see if, like, social groups and or faith groups, etc., that are meeting, if we were to share some of this information on a deeper level, can we collaboratively look at a stronger focus on, for example, through things that are already happening? Or, as I said at the start, if we had more resource or could shift some resource to go and make some of those decisions together with some of our community groups about what already exists, what can we do through what already exists, and what might need some small bits of seed funding to help expand, or that we can certainly share who might be in that local area receiving care and support in adult social care, or just starting to contact us, that we might be able to plug in to some of those things. So being really, really strengths based about it. And just to also share, nationally, there's been a strong focus on prevention for a long time, but there are some groups that are starting to kind of gain some traction that are really useful to us. So Nottinghamshire County Council have got a place into a group that is looking at building the prevention case much more strongly for older people in the adult social care and health space. So they've got 12 local authorities. We went through an application process. We're one of those. They're really interested in what we're doing, along with the LGA, Local Government Association, and 2 national consultancies, big consultancies. So that starts next week. So I'm going to be really interested in what's going to be useful for Nottinghamshire and what we can influence into that. Certainly that business case for funding, we want to be really vocal about, but also through the National County Council network, there's a group that is just starting looking at support for in a more preventative way around people with a learning disability, working age adults, and autistic people. And I think that two-way plugging in with some of those national conversations is really helpful to us at the moment. So, thank you.
No, thank you for all that information. Are there any comments or questions? Councillor Smith.
Yeah, thank you, Chair. Thank you, Katie and Lucy, for that. And I'm going to flex slightly and say that I have read the whole report, and it is very meaty. It is very detailed, but do give it a look through if you are at all able, because it is filled with a lot of good stuff. We said in the last few items the importance of collaboration and the need for what we're talking about to lead to action. So I'm particularly pleased that this not only recommends collaboration, but it is the start of a process as well. So I'm very keen to see that in practice. I'm also reliably informed that this is the first prevention JSNA, not just in the region, but in the country as well. So I do think this is a very important step that we're taking, Chair, and I think it is worth kind of flagging that and getting behind it if we are able. Chair, I've made a lot of notes, but they're very scribbly, so I'm going to leave it at that for now, Chair.
Thank you, Councillor Smith. Totally agree with you. It's something we need to take forward and fully support the prevention strategy moving forward. Professor Kim, if you want to come next.
Yeah, no, this is really, really useful. And I just wanted a few things to develop on it in terms of the data that you've got, whether you can model some of these things, and then looking about sort of the investment that could happen in the prevention space as well, and also whether that data then could be shared with voluntary sector partners and others as they're looking at funding bids, etc. as well. So I think there's a real opportunity of that. Partly then is about how you make that accessible and usable as well, and whether things like dashboards, or whether there's people that the voluntary organisation, when they're putting in funding bids, could talk to as well to get the evidence base for that. And then in terms of from an evaluation point of view, understanding what works in that sort of situation. So I think there's a lot of opportunities for collaboration, but there may well be advanced centre space, a little bit of either making that accessible or upskilling people to make sense of that would be really, really useful. And particularly then, as this is, well, it sounds like the first national approach as well, then taking that and understanding what's happening here and then what could be learned nationally could be a really useful thing as well. And I think the drive towards a more preventative approach is is obviously something definitely to be applauded. The social inequality part is obviously really stark as well, and I wonder then how that might get framed when we're talking in a more assets-based approach. So how can we work with that issue? We talked already about multiple deprivation and various other things like that. So I think this is where how you then engage with communities, given that the issues are quite stark and quite difficult in such a way that doesn't then make people feel disconnected from where they are. I think that bringing the last two items together is a real challenge. It'd be really interesting to capture your learning about that and reflecting on the previous one about language. So you're almost documenting and capturing your challenges, your mistakes, your learning as you go through to help others. Because I think it's an embodiment of what was in the previous one would be really useful as well.
Thank you. I completely agree, and there's a lot of appetite for if we can use this information, any of our information, and make it more accessible and usable. And of course, we're going to build on this through, we've got lots of other information and mapping that exists, but how we make that just sharp and kind of easy to access for groups that are bidding for funding, etc. We're really keen to work on that. And also Viv and I have talked quite a lot about how can we collectively help with that kind of softer evaluation, testing and learning that is really helpful to lots of groups that are trying to access funding and have to put that into bids, etc., to keep growing things in this space. So absolutely would love to be hand in hand about that. Just a disclaimer, we keep saying that we're the first place in the country to have done this, only because we couldn't find another one anywhere else. So we will continue saying that until we do find one. And I have checked through some of my national networks. But yes, I completely welcome that working together in that way.
Thank you, Councillor Warnock.
Yeah, thank you, Chair. It's a situation that it's been going on for a long time. We're talking about improvement and prevention in adult social care, because we want to be reminded of ourselves that adult social care covers a multitude of services, and that is why the department has troubles with its resources. It's never enough to deliver all the services it provides. The reality is that successive governments, whoever they are, have failed us over this crucial issue. It's a serious problem that needs addressing, the funding model for social care. We actually need to give local authorities like Nottingham and Nottinghamshire the appropriate funding they need to deliver these vital frontline services. I mean, where you live, put it on the screen, where you live will determine your life expectancy. That's terrible to actually say something like that. That's a position that we're living in at the present time. Where you live will determine your life expectancy. People that reporting that it's loneliness that causes all the problem as well. I mean, we certainly get the care and support at the present time. There's seems to be a lot of anomalies as well. Some of the private work that goes on, it's questioned so many times. Not me questioning it. It's in the community that it's being questioned that there's a real problem. It needs investigating. It really does. I'm sorry, but that's the situation. As I say, if we protect and deliver on social care, we'll help ease the pressure on the NHS services going forward. Because, as we all know, there's not enough money being provided for all the services in NHS care. It doesn't matter what it is, there just isn't enough money to go around, and that's primarily the reason that we're all looking at ways of means of supporting social care and everything. But it's a funding problem, and you'll never really do as much as you can possibly do without some more funding. I mean, we need to focus more on prevention, of course. People's lives need to be looked at. Why are they getting these problems at 40 and 50 and 60? There must be reasons behind it, and it needs investigating. It really does need investigating, so that we can help people live longer lives as well. You know, that's the sort of thing. How do we get a prevention program that will work? Getting people mobile and having daily exercise is a starter. You know, it really is, because people have got into a habit of just sitting about, and I see it as when I go into houses to talk to people about other problems and so forth. I see that it's a real problem, that obesity is within us. The supermarkets could help as well by providing some cheaper food, which with less calories and this, that, and the other. But they don't bother, just put everything on the front shelves and everybody buys it. You know, it's an incredible situation. I mean, a prevention program, it's having a stable home, an excellent diet. It's more work needs to be done in this area of looking at people's lives and listening to people's views out there. Certainly, more intervention work needs to be investigated. It doesn't matter. It shouldn't matter how much it costs, because in the end, it will save money. Because you're getting people not needing the services that we're so overstretched at the moment, and it's just absolutely essential that we do that. And as I say, also we should be getting in touch with churches. We should be getting in touch with community centres. All these that have knowledge of what people's how people live and how people work and do everything. They have more knowledge than we do, because they can constantly see all the people going to these places and trying to, and they talk to people, they tell people how badly they feel everything is and so forth. But it shouldn't be that situation, you know. So, as I say, Chair, what can we do? Intervention. We've surely got to look at that more consistently than we do at the moment. Thank you very much for listening to me.
Thank you, Councillor Wilmot. Viv, did you want to come in?
Yes, please. Thank you, Chair. So, building on what you've just mentioned, though, Councillor Wilmot, this is one of the ways that we can really think around how do we further embed prevention in what we do. And I think there's a lot to acknowledge around. There's a lot of burning platforms around our system. We know that we have significant financial challenges across a range of our partners across Nottinghamshire. And I think one of the things that we were really trying to do here is really think around how can we be really clear around what works and where we should invest, so that we invest today, so that some of our burning platforms of tomorrow are not 3, 4, 5 times worse, because we know we've got an ageing population. We know that we're getting more complex needs, and if we don't do something today, then there's going to be more demand on our services across the range of this partnership, not just adult social care here. So I'm really pleased to see this. I want to thank Katie and Lucy, and also Will Leather, who's done a lot on this, and so is Kate Carmichael. So it's been a real joint effort on this. But I suppose there is something here around the fact that this is not just an adult social care problem. This is something about how we can all resonate on this. So if we think around some of the drivers for adult social care, they're also significant drivers for health care as well. And we'll also link into some of the other demands across the broader partnership here. So, there's something for me around how do we link around some of the drivers around frailty with, I know, some of the ICB work that's going on around frailty. How do we link back to some of the work that we've just talked around from the communities JSNA around supporting our communities to thrive, and how we can reduce that loneliness and build into some of the conversations we had around supporting our carers, supporting our voluntary sector in some of that. the other area for me that I wanted to highlight was around dementia. We know that dementia is a real driver across adult social care here, but there are things that we can do, even if it's around advising people to get their NHS health checks early, because we know there's some dementia diagnosis in that. So how can we all consider our little part of that? So I really welcome this, and I welcome the future adult social care prevention strategy that will fall from that. And I'll be really keen to have a conversation around how we can all collectively come around that. But I think the other thing that I did just want to highlight, and it picks up on Professor King's point, was around some of the work around the joint strategic needs assessment. So there is something that we are thinking around, and it's part of the work of this board, is around how do we develop the joint strategic needs assessment to make it right for us? How do we make it more accessible? How do we ensure that it's meeting the needs of the range of this partnership? So please do give us that feedback, because if it's not hitting the mark for you, then there's something that we can do around changing that, because that's within our gift to shape that. And all of the chapters that you've seen today and the previous chapters are all on the Nottinghamshire Insight, so we can make sure that that link is sent out with the minutes for those that haven't seen it recently. But in terms of future thinking, one of the things that I think is really significant here is around the trend in our women's healthy life expectancy. So we know that that is going in the wrong direction. We know that women have longer lives than men, but they have more years in poor health, and we know that they have greater health inequalities in that. So it was just to give you a bit of a bit of a heads up, really, that we're doing a bit more deep dive in that, because we know that's one of our key health inequalities that we want to look into in a bit more detail, and we're going to be bringing sort of JSNA or DPH annual report on that later on in the year, because I think that will hopefully help to unpick some of the questions that that this has given us, because at the moment we've got women living to 82 odd years, but 20 of those years are in poor health, and there's things that we can do to prevent that and avoid that and delay that. So it's really about unpicking what we can do on that moving forward. So that's all I wanted to add. Thank you.
Thank you. Lucy, did you want to come in as well?
It was just one final piece, and it's to go back to Councillor Smith. I'm delighted to hear that you've read the JSNA in its entirety, but also to go back to Professor King's point about data and availability to partners. Just to let you know that the profile pack that you've seen in with your papers, I think, is sort of 30 or 40 pages long, to hopefully try and make it a sort of digestible and usable format, and that's what will be published online. But sitting behind that is around 250 pages from the full evidence review and data analysis that's split into chapters around things like older adults, frailty, disability. So if there are any partners who are interested in either seeing that full cut or in particular elements of it, again, just like with the screening immunisation data, please just get in touch with us, and we can make that available to you, even though it won't be published in the public domain.
Councillor Tidesworth.
Thank you, Chair. Yeah, I wholly agree with Councillor Wilmot, majority of it. We do need to make sure that the care is accessible, appropriate care is accessible. Unfortunately, it has become disjointed, well disjointed, actually, if truth be known. Once upon a time, we did have our own care homes, but we haven't anymore. The other thing is there are so many things we need to make sure that is accessible at the right time. Even doctor surgeries, there is a lack of nursing, care nurses, community nurses. These we need to be seriously looking at and resolving some way or another. Because I know a couple of friends of mine have come out of hospital and it's been delayed because they can't get appropriate care. And this is still ongoing now. It does need redressing and sorting for quality of care for everybody.
Thank you. Councillor Crosby, you're next on my list.
Again, it's wrote down. I think it ties in with what you were just saying, that different people, different parts of the healthcare service, it's not one particular bit of it. So I think this is fine for this bit. The Institute of Health Equity produced a follow-up to the Lives Cut Short report published in January. The new report, England's Widening Health Gap, Local place has fallen behind, emphasised how the north-south-east health gap has increased. People's health has deteriorated and health inequalities have widened. We were alerted due to particular concerns, trends of health in our area. This is Newark. Since 2010, the local authority of Newark and Sherwood is one of 14 areas most affected by increasing health inequalities. Health inequalities between the top and bottom 10% of local areas in Newark and Sherwood have increased by more than 4 years for women. This is compared to the English average of 8 years. 0.8 years. Newark and Sherwood has received cuts in real terms to its spending power per head of population of 98% in the decade since 2010. This is compared to the English average of 33%. On occasions, Newark and Sherwood is often regarded as a leafily affluent district, but the reality of this report and data doesn't reflect that, and we request the Health and Wellbeing Board to take note of the recent findings and respond and support where possible, please. Thank you.
So thank you for raising that, Councillor, and I think a range of partners are struggling in a similar vein. I'm not detracting from the real pressures that you're obviously feeling in Newark and Sherwood. I think what I would say is there's something to really think around in terms of we acknowledge that there are health inequalities in a range of different ways. So whether that's geographical, and we've talked a lot around that between our most deprived and our most affluent areas, whether that's different particular groups in terms of, we know, the particular ethnic groups or particular inclusion groups, which may struggle with a range of ways. What I would say is that we have a range of data around this, and it's something that the public health team work very closely on, and we do a lot across within public health, but across the range of this partnership around how do we reduce health inequalities. If there's any specific work that we want to do, if you would like any specific support or anything, please get in contact with me. We can more than happy to help on that, and that's an offer out to everybody in terms of how the public health team can support you. But we will pick up specifically, I would imagine, some of the specific women's health areas in the broader JSNA chapter. So that will cover around women's healthy life expectancy. So that will cover the whole of the county, but we will absolutely make sure that we're looking at those geographical differences at the different district and borough patches within that, and really understand what are the key drivers around that. So we do know some particular disease prevalences and some of the risk factors around that. So we know that tobacco control is one of the most effective things that we can do. So if we can really reach out to getting a smoke-free generation, that's one of the best things we can do. We've touched on around obesity earlier. We know that's a key driver for a range of health and wellbeing conditions. Or other things around our general health and well-being, but also really thinking around those building blocks of good health. So what are the things around us that help support our health and well-being? And we're really keen to think around how we have further conversations in the Health and Wellbeing Board around how are we ensuring we have good, safe homes, how are we ensuring that we have the economic opportunities for our populations. We've had a conversation around communities today. So again, I think there's a range of things that we can do, and it's such a complex area. But if there's any particular area that you would like to deep dive on, then just give me a shout. Thank you.
Thank you for that. Helen.
Yeah, I'm mindful of time, so I'm going to make this really quick. There's a few things that we've done in the South Notts Place-Based Partnership that would be great to connect with you, Katie, particularly around falls prevention. So any of you that were involved in the ICS Health and Care Awards, Sarah Davis was shortlisted for her work there, and we're trying to spread that in the 4 integrated neighbourhood working areas. And also in Broxtowe, there's been a great piece of work around people with learning disabilities that would be really important to include, and adult social care colleagues were part of that, so you may be aware of that. And finally, there's been a piece of work in Rushcliffe specifically around dementia. So again, some really great learning that we're now looking at spreading across the whole of South Notts in the prevention area rather than the medical area. Thank you.
Thank you for that. Councillor Ellis.
I just wanted to say that I've noticed
the data used in the JSNA tends to be drawn from national data sets. So that's a pretty sort of standard age group rather than a decision we've taken locally to use 65 plus as a cut-off. There's also quite a lot in there about 85 and above, so that further end of old age. But absolutely take your point and wonder if actually as part of the next steps with the development of the prevention strategy, we could have a look at people who are remaining in work later in life and whether there are any particular aspects there around social care need that we need to consider. So absolutely a really helpful point, thank you.
Councillor Smith, do you want to come back?
Yes, thank you, Chair. I will be brief, but I just wanted to come back on some of the points that Councillor Wilmot raised at the start, because I thought there were some good points in there. I don't think there's a government or council department in the country that wouldn't benefit from, on the planet, that wouldn't benefit from more money. But I think this is a good example of the department doing innovation, doing good things with the budget that they have. He said as well about looking at the causes of the things we are trying to prevent. There hasn't been a report, I think, come to this committee, John, that's not talked about diet, where you live, and how much you move. So I'm going to guess those are the three causes that will continue to come up as long as we as a species exist. And the point you said about getting churches involved, absolutely agree. And I think that's part of the department's wider kind of sense of collaboration, not just churches, any kind of community aspect. I absolutely think that they are on that, and that is, completely part of their collaboration view.
Thank you for that. Is there any more comments or questions or no? No. If everyone's happy, then can we accept the recommendations? Then please, can I just have a show of hands, please? Thank you very much. Right then, I'm really conscious of time, and we've overrun quite a bit now. So we have agenda item 8 is the Better Care Fund, and the report covers multiple items, including the end of year Q4 report 23-24, the 24-25 plan refresh, and the plans for the use of additional discharge funding, which was submitted to the NHS England as part of the 24-25 planning template. Before I hand over to Katie, can I have a seconder for the recommendations on page 60? Thank you. Katie.
Thanks very much. We can do this very quickly. This is a well-rehearsed route that the submissions to NHS England and the dates set there don't fit with our local governance timescales, and often we get the templates very close to submission dates, which is why we're not able to plan it any earlier. So yes, this is just asking to approve last year's year-end report that has already been submitted. We did meet all of the criteria. This year's plan for our Better Care Fund is the second year of a 2-year plan, so it's a light refresh that did. The 2-year plan did come through last year, and then the additional discharge grant, which is very welcomed, that is for this year. And just to give you some stats, this covers a whole range of things, including our carers support that has been here and is co-produced, prevention services, rapid response technology, but also a big focus on hospital discharge and avoiding people going in. And in terms of metrics that we're measured on, our residential care admissions, so reducing people going into residential care, we are just 4% out, and we are improving. Our avoidable admissions, I'll bring Naomi in to answer that. We've achieved our target in terms of reducing falls. Our discharge to people's normal place of residence, i.e. their homes, is very slightly off target, but our data and our ICB data shows that we are meeting that target, so we're querying that at the moment. And in terms of reablement, we have 85.5% of people that are able to stay at home, which means that we're achieving and exceeding that. So we're asking that you are able to approve those plans, please.
Did you want to come in?
Just on the avoidable admissions, it's very slightly off target. It's a locally set target, it's a couple of points off. So yeah, we've set it as the same for this year we're in now.
No. Absolutely. Any comments or questions? Councillor Wilmot.
Yeah, just a quick one. I see the Better Care Fund was created, if you remember, to reduce the barriers between the NHS and local government. It has worked. I think it has worked quite well, although there are one or two conflicting reports of incidents that have taken place. The main aim for all the funding is to make the system work. You just have to do that. But let's look at the statistics. National objectives were to enable people to stay well, safe and independent at home for longer and provide the right care, the right place. Now, this template, this BCF national reporting template, it puts out 5 issues, and it says that 3 are not on track. You just said that they're near to being on track, and but it just looks so bad in the report. Affordable admissions. This metric is not on track to meet the target. Discharge to use your place of residence. It's one of the most essential things that when you've been in hospital and you need to get to the your place of residence, it needs to be done quickly and without stress. But it says the metric is not on track to meet its target. And the residential admissions, this metric is not on track to meet this target. So the report says 2 are on track and 3 are not on track to meet the targets. So is this report right? I mean, however, I can see that you've got plans to address the problem, but I do hope they'll work, because it says not on track, and that's in black and white situation. I just wanted to ask that question. Will it work? Will these avoidable admissions, discharge to use your place of residence, and residential admissions, will they be brought onto track, and how long will it take?
Well, we think that the target around discharging people to their usual place of residence, we're confident that it is on, that we are meeting that. So our data and ICB data show that it is. So we're querying that one nationally. So where we are slightly off target is where we've got too many people going into residential care, but it's showing that our journey, we are improving. We're only 4% off the target. And I think it's a really important target. We want to get as many people home as we can. I think we're working very hard locally on that.
Great, thank you. Councillor Wheeler.
Yeah, thank you, Chairman. Briefly, I know I mention it very often from Rushworth Council point of view, but I think the Civil Facilities Grant's a key part of this, and of course we still have the system where there are some councils who are not getting enough money out of the way the system currently is, and so we've got waiting lists for people to get the adaptation to their homes, which obviously has a knock-on impact on the discharge rate and what's getting people locked into residential care, things stay in their own homes longer. And we've got some councils who are effectively don't have the demands. They're taking the money is in the bank account, which they're not spending because they don't have that demand, which I get. So and that affects like the postcode lottery we said before. That's another postcode lottery we're sort of creating the current system. So those are pleased to colleagues when this is brought up, I know in various forms like Chief Officer Forum, etc., to look at with the current way it's set up, it takes all district and borough councils to agree to change it. So I just ask people bear that in mind. It could be 1 year there are 1 or 2 councils who will benefit from who will benefit from a change of formula now. Then it could be in a year's time where the demand shifts. That those other councils that go, actually we could do the money as well. So it wouldn't just be a permanent change to other councils. It would be a demand-led approach, which I think would be much fairer for residents across Nottinghamshire. Thank you.
Yes, just to respond to that, the DFG Disabled Facilities Grant formula methodology was set in 2008, and it's been discussed extensively locally, and I think we would support a change in that formula nationally. Yeah.
Thank you for that. Helen.
Yeah, thank you, Katie, and thanks, Naomi. Just we've talked a lot earlier in the meeting around strength-based working, person-centeredness. It doesn't jump out of you in this report, and I appreciate it's a bit of a numbers report, but I guess just a challenge on page 204 around the joint project with the ICB reviewing higher cost jointly funded packages. Can we have an assurance that that process has been doing in a strength-based, very person-centred way to look at what the right thing is? And similarly, the collaboration and information sharing across health and social care, it's all about roles and process, not about culture and ways of working. Is there any assurance that that's that's happening in those pieces of work. Thank you.
Thanks, Helen. So the first bit about the strengths base isn't coming through the report. So the templates are set by NHS England, and they're very statty in a certain way. So I agree with that. Doesn't necessarily allow some of the messages that we might want to come through. I think if we were to lift out certain pieces of work, so Better Care Fund funds all of the work that we do around our carers strategy, which has been really strengths-based, completely co-produced. We meet with we have a key carers group and commissioners group that meet every single Tuesday, and we are gradually working through the entirety of the way that carer support works and making sure that it is strengths based and works well. And we've got some really good impact that came after the first year of that strategy. So I think behind some of this is a real strengths based and co-produced approach. I think your point around joint funding, it's a live issue. There are a lot of pressures across our system and financial pressures, which means some things are being done at speed. I think certainly from a county council point of view, we are trying to make sure that we work in a strengths-based way when we are jointly assessing people. We're also bringing on online a piece of work that is about working jointly with the person receiving support, the setting that they might be in. So it might be a supported living setting, for example, to look at that whole model being strengths based. So it also be about that joint assessment, but also the model of support that's there, and also looking at positive risk taking within that. So for example, having technology rather than overnight staff, because a lot of people don't want people in their homes at night. So yes, that is the aim. There's a speed to some of the financial work, but I think Naomi, feel free to come in. I think we're trying to make sure we stay in a place to be as strengths based as possible, aren't we? And I think there's been a bit of clunkiness at the start, but we are into a joint space that is trying to make sure that we're really working together on that, aren't we?
Yeah, and I think just to add to the point about the shared data is really good locally, but it is about flow. And I think within that urgent emergency care governance, I think they are wanting to look increasingly at experience and the culture and having. I know now in their performance meetings they have case examples that we look at collectively. So all partners around the table looking at case examples to learn from Discharge, not just looking at the stats and data. So perhaps we could highlight that in the next report as it comes through.
No, thank you for that. Are there any more comments or questions? No? Can we have a vote then on the recommendations in the report, please? Can we have a show of hands? Thank you very much. Right, I'm really sorry we're running behind time, but not so much time now. So let's move on to the work programme. So the final item on the agenda is the work programme, which is set out on pages 215 to 220. Board members are asked to note the work programmes and to make any further suggestions for inclusion that we'd like to see. So can I formally move the recommendations on page 214? Thank you. And are there any comments or queries or anything we'd like to see added onto the work programme? Helen?
Sorry, just one quick point. The LGA review of the Health and Wellbeing Board isn't noted here, and I know there was going to be a workshop in June, but that was obviously postponed because of the election. Is there an update on when that's going to happen? Because that feels a really key piece of work. Thank you.
So I'm going to defer this to Lizzie in terms of, yes, it's definitely being rescheduled, but I'll be honest, the top of my head, I can't remember what date. Have we got that in, Lizzie?
Yeah, no, thanks, Helen. It's so we're planning to reschedule it for September, so we'll be confirming a date shortly. Essentially, now we've got a new chair in post.
Are there any other comments or questions, Councillor Wilmot?
Just again to reiterate that it's been taken off now. That about the possible new Hucknall Health Centre. If you remember me talking about it the last 2 or 3 meetings, I just wondered if we'd had any news from the NHS about that, and if it's possible to get them here to talk about it, because you know it's an issue that's been ongoing now for nearly 6 years.
Was that on the health scrutiny?
Health scrutiny, I think, is the other agenda.
Upon?
Health scrutiny.
Yeah. Yes,
yeah,
it was talked about there, but it needs to be talked about here as well. You know, but because you know, it's as I say, it's now nearly 6 years since it was first thought about a new health centre for Hucknall, and you know, the NHS got to the position where they're asking where it was going to be, and since then it's gone off the.
My understanding is that there's been some changes and some different information, isn't there? But I don't think this is the place for it. I think health scrutiny is probably that place. But I'll have a word with Roger, Councillor Jackson, and we'll work out.
See if we can get some news about it. You know?
No, thank you. If there's no further comments or questions, thank you very much. And I'm sorry we've ran over slightly. But I think moving forward, we've definitely got to do more of a doing and bring everything together, because I think all the reports come into each other, don't they? So I think, and thank you very much for your patience today. Thank you.